Today we're talking to Dr. Michelle Lee. She is a comprehensive dentist in Fleetwood, Pennsylvania, doing all aspects of dentistry except endo, you'll learn through our discussion. So she has become a leader in teaching things in the TMD, occlusion, equilibration world through her activities at Pankey, and she was the program chair at the most recent AES meeting. So we get to hear a lot about her, how she found dentistry, what her education was like, and her practice trajectory, and then what she loves doing in dentistry. So listen in, it's a good one. Before we get started with our talk with Dr. Michelle Lee, we have a little bit of housekeeping to take care of. If you weren't there in person, our February 26th, 2021 virtual online meeting was a success. The content was fantastic. We had all the speakers we intended, and it just was online. And the cool thing is that is still accessible for you online. Go to aesvirtual.org. You can sign up, you can get registered and join. And you'll get not only the 2021 meeting, but you'll also get the archives. Those digital archives are extremely valuable. And this is something new that we're doing that is just amazing. So check it out, aesvirtual.org, and all the info's there. While you're there, you can also check out the other podcasts, just saying. If you want to know more about the 2022 meeting that is coming up February 23rd and 24th, that is at aes-tmj.org. And that meeting is going to be packed full of creating smiles as a serious business. With Whit Wilkerson as our program chair, there's a heavy focus on TMD, occlusion, and airway. With adults, children, orthodontics, there'll be case studies, and we'll get into some other digital workflow. There's even going to be a talk about robots. It's really covering some bases that we haven't talked about in depth in a little while. So please plan to be there back in person, hopefully. And okay, today we're talking to Dr. Michelle Lee. Tell me about you. How did you pick dentistry?
Oh my gosh. Well, it is one of those things where I grew up. So I'm going to go back to kind of childhood. So my parents immigrated here from South Korea in the late 1970s. And I was actually born in Milwaukee, Wisconsin. I don't think anybody really knows that. It's like my really close friends. That's like the little trivia, that it's like, where was Michelle Lee born? Type
now
deal.
We're going to be able to decipher all your passwords.
Yeah, exactly. All the Michelle Lees, just birthplace, Milwaukee, Wisconsin. So I actually belong to our Midwest Acorn group, and they always pick on me because I'm not actually practice out there. And I said, I have birthrights here, people. I belong in this group. Mm-hmm. But so my parents sort of immigrated here, and they moved to Pennsylvania when I was little, and my mother, both my parents were blue collar workers. They're just, I think, part of the value system with me, with just sort of work ethic and just kind of having a deep gratitude is based upon sort of your childhood memories. And I just remember my parents just working really, really hard for just all the opportunities that they have given us. So my mother got into jewelry, actually, and she actually opened up a really small jewelry store, and I grew up working with her. Wow. And I grew up working with my hands, and we would do some simple, fun soldering, and we would design jewelry together, and that kind of evolved where I loved science, and but I loved working with my hands, and I love people. And my parents, or my father, suggested medical school, but I didn't ever think that was a good fit. And I went to Penn State undergrad, and I actually did a lot of research. I did some entomology research. I got a scholarship at the NIH Institute to do some oncology research, so I got to do that. So I took a half a semester, and I got a fellowship to do some oncology research on breast cancer cells. And in doing that, I realized how much I loved sort of the science part of it, but how much I was yearning for some of the relationship part of it. Because yes, you're in a group doing some really fun, laboratory experiments, but at the end of the day, I felt very I felt very alone, so I knew that I wanted to go in the science route, but not necessarily do the research route and not necessarily go the medical route. So I like early on, I didn't even want to take my MCATs. I was like, a test that's like 8 hours long? No way. So I was like, okay, that was a good readout system for me. And then my mother's really good friend, her daughter got into Penn Dental School. And this was like, I was in my senior year. I went to Penn State undergrad, and I was in my senior. I was in my fourth year, and I really didn't know what I wanted to do. And my mother made that suggestion. She said, you love working with your hands. You love people. She said, why not dental school? Mm-hmm. And I had like okay, well, maybe, right? So I literally applied to just 3 schools because all the applications were like overdue and I'd be late. And I literally kicked my applications underneath the door. I got them in. And the one school that I got into was Penn. Wow. So awesome. Yeah. So, and that was my first choice. We lived outside of Philadelphia then, and I wanted to be closer to home and be close to my family. I'm the oldest of 3 girls in my family, so we're very close. So just to be closer to home and just pursuing another sort of dental career, I thought that was a good fit. So some great times at dental school, good and bad times, but so that's how I kind of segued into getting into dental school.
Yeah, awesome. Did you end up doing any more research in dental school?
So, yes and no. I sort of, I loved research, and so there was a few opportunities for me to do research, and I started to do some of them. But what I realized was I just love just being working with my hands. So what I ended up doing was I ended up being a TA, or I'd be like a teaching assistant, or I'd find myself kind of gleaning on some of our mentors in the clinic and asking them more about procedurals and materials and whatnot. So, Penn has such a wide variety of research opportunities, and I actually teach there now. I actually teach their microscope restorative program there. So, my group leader, Alan Atlas, he was my group leader, and one good friend now and mentor. We had kept in touch for many years, and he had developed a microscope program utilizing the dental microscope for restorative dentistry, and he invited me to teach with him. So I have been doing that with him for the past 3 years, and I loved it so much so that after 3 months of actually going in there, I told him, I said, well, I love the idea. I love the program. I said, but I have a full-time practice, so it would have to be on a Wednesday. He's like, it's on a Wednesday. He's like, what do you think? I was like, well, second of all, I don't own a microscope either. So he's like, come check it out, see if you like it. And it was just, there's few things in my life that I say that's changed my life, and just utilizing and understanding how to use a dental microscope has really changed my perspective on things. And so within 3 short months, I ended up buying one myself. So it's been lots of fun.
Did you learn on one in school then?
Yeah. Okay. Yeah. I actually, wow. Yeah, I was in a group, and the first couple rotations, I was with the 4th year dental students. So I was with the D4s, and I sat down, got in front of a microscope, and started prepping on typodont teeth, and learned how to calibrate myself, and then learned how to calibrate the dental students. And, I'd have to say Alan Atlas was just really instrumental in sort of getting me on board and teaching me. But that's what he's passionate about, and that's what he teaches. So he teaches actually nationally and even globally about dental microscopes. So it's been a really great wave to be a part of, and I'm super honored to be able to give back and go back to the dental school there. But yeah, so I sat down and had a typodont in my hand and started prepping, and yeah, it was just definitely just a world opened up for me.
Cool.
Yeah, so lots of fun.
How much percentage of procedures do you use it for in practice now?
I'd have to say I always want to do more,
Yeah.
so I've had my microscope for 2 years now. So, and, as you know, it's all dependent on how much time you have, during a procedure. So if I would have a class 2 restoration and my next patient, I'd have a little bit more time, or I didn't have a patient next, I would actually utilize or definitely give myself a little bit more time, because initially there's a little bit of a learning curve.
Sure.
But with great value, of course, but a little bit of a learning curve. So I'd have to say maybe about, I don't want to say about half.
Yeah.
About half maybe on a good day, I think, because I have a mobile dental microscope in just one room. And in my mind, I envision myself just wheeling this microscope from room to room, be like, yeah, it's going to be a part of me. I'm going to take it to room. But you realize it weighs a ton.
Yeah.
And it's one thing that you say it's mobile, but it's not quite so much so. So it's actually in one of my operatories. I have a 5 operatory practice. And so it stays in one of my operatories. And so I normally just intentionally schedule patients to be in that room. So I do all of my anterior sort of restorations or prep, crown preps, veneers, all of my anterior stuff. It's really, really easy. I want to say much easier. And more conducive, and it motivates me more to use a microscope from just premolar area. And if there's a molar area, I'll sometimes utilize my dental loops and then do the preparations initially, and then go back and maybe do some fine finishing. Because as we know right now, there's a lot of digital technology, right? And so it all depends on not only your scan, but it actually depends on your prep.
Yeah. Okay, so what is the progression like from no loops to then low power loops? And then what I'm familiar with is moving up the progression in loop strength, and then jumping to microscope. It seems like an even bigger jump from a magnification standpoint, but also, as I think you were just kind of alluding to, the patient management, positioning, that kind of stuff. So what does that progression look like, or how do you teach that progression to people?
Yeah, so one of the things so I have a Zeiss microscope, and just as a disclosure, Zeiss does not pay me, to talk about Zeiss. I only present on things that I'm passionate about. And I have a Zeiss microscope in my practice only because we have Zeiss microscopes at the dental school at Penn. So my loop magnification now is 3.5. And the biggest learning thing was, I'm a very start with why person. So for me, it was like, why should I use a microscope when, I can easily see well, and actually I can get a 3.5 magnification loops, and I can also get like a 6, and I can get higher, and I can actually kind of see much and not have to spend the finances on it. But what I learned about the microscope, it's got a binocular sort of optics where it doesn't actually contract our optic muscles or ciliary muscles in our eyes to actually focus. So when we actually focus on an object, right? So we have an object out here. If we want to focus on something, what do we do to the object? We bring it closer, right? And what that does, it contracts our ciliary muscles, right? And it causes somewhat of a muscle strain. And then when we don't, or when we need a break from that focus, right? What do? We break the focus, and we look at the horizon, right? And so we have to just kind of clear our eyes. So on the microscope, you get the magnification without the muscle contraction, and it's as if you're looking out into the horizon.
So less fatigue.
Less eye fatigue. Yeah. And so there's less eye fatigue. There's extraordinary illumination. And ergonomic wise, I feel a lot more relaxed. And so, our profession is very, I think, physically demanding. And I think as we get older, we realize those things, that we can't kind of do this motion anymore, or this motion, or, I always tell the dental students, this mirror, right, is to be used and not used as what? retraction.
Right.
We're like, yeah, we use it to retract. I'm like, me too, but we can't do that forever, right?
Yeah.
So those are the things that was a really big aha moment for me, where I didn't see sort of the big picture, but in learning sort of the actual details of the microscope, those are the benefits.
Mm-hmm.
So I have a 3.5 mag, and then it starts at 4, and then it goes to 6x, 10x, and then it jumps to 16 and then 25.
Wow.
So obviously our endodontics, right? In endodontics, it's a standard of care.
Mm-hmm.
Right. And so it's interesting how much they can see and how much magnification that they can get. So how do we utilize that in a dental practice? So for me personally, I have learned through just my journey through just amazing organizations like AES and the Pankey Institute, and all the mentors and the giants that I've been able to stand on, said, if there are certain procedures that you don't like to do, you don't have to be the jack of all trades, right? That's okay, right? So I picked like my top 3. I was like, okay, like, how am I going to make it though? Like, if I don't do everything for everybody, like, how am I going to make it work? Right. I'm just like, I just started a practice and doing all this. And the 3 procedures is endodontics, and endodontics. So those 3, right. So I decided, I was like, if I don't feel comfortable, right, or confident doing endodontics, how can I bring endodontics to me? So I host actually an endodontist to come to my office, because I have a microscope, 1 day a month. And obviously, if there's emergencies, if there's any other procedures that they need to see, right, my interdisciplinary team, right, that I refer to, they will go there. Mm-hmm. But if they are able to, I actually offer that convenience. And so how to incorporate that into a dental office, you can actually host a specialist in your office to be able to do procedures that you're not comfortable doing. Second of all, there might be certain procedures, especially with our digital design, with a lot more CAD/CAM technology and scanning. If there's any undermined or irregular preparation, sometimes the scanning and the milling, as we know, it starts from the prep. So I've learned that there's a very precision-based dentistry world that we're entering. So I set aside a little bit more time to be able to prep, whether it's a loop, but I always try to finish with a dental microscope under higher magnification, so that I'm picking up with like that high, that 847, 014 burr or 017 or 016 burr with like that red fine polishing burr to make sure my preparation is nice and smooth. So I think those are the things that you kind of have to figure out what best fits your practice. I don't think there's like a formula, but from speaking to others, I think if you're able to have definitely more microscopes in your operatories, maybe, and that's a goal of mine, is maybe to have maybe 1 more in another operatory, so that I can actually have more of a consistent sort of dental microscope workflow. But with having it in 1 room, I'm just really happy that I can still be able to do that.
Yeah. That's great. And how did it or does it affect your assistant? Do they have to learn different techniques and movements to work around the microscope? And the fact that you're not moving now means they're not moving as much, maybe?
Yeah. So there is a monitor that there is on the lens of a microscope. It's a circular reticule, or there's crosshairs on the microscope. So you determine, and that's set in your dominant eye. So we've got a non-dominant and a dominant eye. And so that's where our brain funnels through how we see. So we see through our dominant eye, and all the information gets funneled in. Actually, you see, I'm pointing to my right side of my face. Mm-hmm. I'm very right-sided. Mm-hmm. So it funnels in, and then if you're able to center your preparation or whatever you're doing inside that circle or the crosshairs, it feeds into a monitor in real time. So your assistant can see where you are. Okay. So they're able to follow through and actually see your preparations. Yeah. And I actually have the capability on the microscope to actually record and take pictures. So in terms of patient education and just being able to photo document, it's been pretty incredible.
Yeah. Yeah.
Because I'm able to show patients cracks and why per se they're not really feeling it, but we're seeing it per se. And so it's been, in terms of the patient communication and patient education, it's been pretty phenomenal.
Yeah. Cool. I'm going to switch gears. Which did you find first? AES or Pankey?
Oh, geez. Yeah. Definitely Pankey. And Pankey led me to AES. So, okay. Yeah, once I graduated from Penn Dental School, I did a residency. It's right outside of Philadelphia. It's on Abington Memorial Hospital. I did a residency-based training there. And then I worked as an associate. And in that year, I learned what I didn't want. So I actually lasted in that practice a little over a year, and I actually just quit. It was, and I left dentistry for about 5 months, actually. Wow. And it's one of those stories. Yeah, it's one of those stories where you say, then you don't know what you want, but I knew then what I didn't want, and I almost say it was probably a blessing for me because. And I didn't know then, again, what I know now, but it was in complete violation of core values. And so as you grow and develop into a dentist, and as you grow internally and emotionally, you just learn what you value and what's important to you. And that practice just was not a good fit. It wasn't patient-centered. It was everything that was, I felt that it didn't define me. So I woke up one morning, I told my husband, I said, I am not going to work today. And we had just bought a house and we were trying to start a family. There was a lot going on and we were in like total crisis mode. I'm like, I'm just not going to work. And I had like tears coming down my face. I was like, and so I gave notice and I stopped working, and I had Victoria. She's now 13 years old, and I started a family, and I just decided to just kind of pivot and just kind of revisit values and kind of figure out exactly what I wanted. And I figured out that I wanted to buy a practice. And I found a practice consulting company that kind of sat me down. I didn't know then again, but he sat me down he met me at a Barnes and Nobles, and he kind of had like a new patient interview. Yeah, he actually sat down with me and like asked me questions and like said, what do you, all these things that I would ask a new patient about understanding core values and understanding goals. And he said, you know what, Michelle, he's like, I think I have a practice for you. But at that time it was 53 miles from where I lived. It was very, very far. He said, I know it's far. He said, I think you should check it out. So, I mean, long story short, I ended up giving it a try. I drove out there, and it was like I was living in suburban, outside of Philadelphia, and I was going out there and nothing but, cornfields and cows. And I was like, it's really out there. It's really far. But I worked there for 3 months, and I ended up buying it. And nice. What was different about that practice was the practice owner's name was Rich. Rich actually had gone to the Pankey Institute, and what I saw was a very patient-centered, relationship-based dental practice. And working there for 3 months, I saw some incredible bold patients that were excited to be there. Dentistry that I've never seen before, just very occlusion-based, that I just really fell in love with the culture. So in 3 short months, I bought the practice, and he ended up staying with me. So he ended up staying with me and working part-time. He'd work 1 to 2 days a week, and he actually just retired a year and a half ago. So we had a 13 long year relationship together, and it's been really great. But that's kind of how I got introduced to the Pankey Institute. So within the year of buying the practice, I had a baby. Right. Victoria was a couple months old, and I went to E1, and I had committed myself to going to the Pankey Institute once to twice a year ever since. And actually, as you know, I've never stopped going back. Right. And so my AES connection is interesting. Is one of the great things about dental education and kind of being around some like-minded dentists that become your friends and some of them become your mentors is they kind of put your hand on your shoulder and they kind of nudge you along, and they at times believe in you more than you believe in yourself, I feel like. And one of those mentors for me, amongst many, was Glenn, and his connection was he put his hand on my shoulders and he said, "You need to go to AES." He said, it would be a very good learning experience for you. And so that's how I got there.
Fantastic. Yeah. So back to Pankey, you went through Pankey and then you kept going because you're teaching there somewhat, aren't you? So I don't know the correct terminology. Are you considered a faculty or part-time faculty or a mentor, or what does that look like?
Yeah, so I completed many courses there, and super passionate about the Institute. And I was invited to come back as visiting faculty.
Okay. Yeah.
And so as visiting faculty, I think at least a track now, for those that get invited back, you complete your E1 through E4 essentials, and then there might be one or two, some of the focus courses, which they offer yearly, and there's many of them. And there's mentors there that kind of invite you back, and you kind of go through, and then you revisit coming back as teaching assistant, and then you become faculty. So I am a lead visiting faculty for the Essentials 2, where we teach TMD, occlusion, and equilibration, and bite splint therapy. So it's a little bit of layer learning, I think. Also, between all the essentials, we kind of layer on the most essentials. That's why we call it the essentials of comprehensive dentistry. Mm-hmm. And I have a big passion in treating TMD, occlusion, and so I feel like that's a great fit. Really honored to be able to give back to the place that's given me so much. So I'm always excited to do that every year. Mm-hmm. I also give back. I'm an advisor there at the Institute, and I also serve as the board of directors there as well. So I'm on my second term there, also as board. So that's also been extremely rewarding to be able to be a part of some incredible visionary thinkers, to be able to take the Institute and education to the next level. So it's about, mentoring and teaching and giving back. And you asked, like, what are your roles? I think once you kind of become a part of an institute, or, you get to teach, and if you're passionate about something, you're always a teacher and you're always a mentor. So I'm always honored to be able to give feedback, or just to kind of be a friendly voice to some people that come there. So
yeah. Well, since this is AES podcast, it would be remiss of me to not dive in a little bit more to occlusion and TMD and stuff in that world. So I recently was stalking you on Instagram and noticed a beautiful splint that you made for someone a while back that you had shared on there. So I know that there are multiple splint designs for a variety of reasons. Do you have a favorite?
So in 2 weeks, I will be giving a bite splint therapy webinar. There's so many
awesome.
Different bite splints. Yeah. So yes. Actually, Dr. Kimmy Dwyer from the Lehigh Valley Dental Clinic invited me to teach, to do a webinar on appliance therapy in everyday dentistry. So if you're inclined, I can send you the dates, but that I feel like that's an ongoing conversation and a super healthy one, because without, bite splint therapy knowledge and the knowledge in occlusion, I think I'd be remiss to say I think that is probably the most fundamental thing you can be doing and serving your patients in your practice. Mm-hmm. So if I were to say, I want to say it depends.
Yeah.
Right. And I guess if I'm going to go back to that one patient, I think 90% of TMD could be, we can diagnose as occlusal muscle. And I feel like that can be outside the internal derangements and outside sort of the joint stuff. There's many things that we can learn and help patients, direct patients into sort of the next best steps through bite splint therapy. So what I had made for that patient was a flat plane appliance in a adapted centric posture, right? Because we don't never know that they're in complete healthy CR. Once you get clicking and popping joints, I want to say they're not necessarily normal anymore. So I call it the adapted centric posture, but just allowing the patients to get better I guess, with their somatic system, right? With their system. So how can we get patients to get better? That's conducive to joint muscles and teeth with their system. So it was a very simple flat plane appliance. It's one of my favorite ones to make. It definitely is, with a little bit of anterior guidance with nice crossover and posterior disclusion.
Yeah.
Because that's all Pete Dawson stuff, right?
Right. It is.
So
back when
it's our Bible. Functional occlusion is our Bible.
Lines in front, dots in back.
That's what's so great about AES too. Pete Dawson stood on the stage, and we were able to be blessed with his last lecture. And so that's just such an honor, and just one of those won't ever forget memories. So
for sure, that was the most widely sold course as well. How we used to be able to buy the afterwards. I think actually a little plug for the AES new subscription deal. I believe that lecture is one of them that is in the archive, if I'm not mistaken. So that right there would be worth the price of admission.
It is the best values proposition. That is a must-have, presentation. And I agree with you. If anyone can sign up for that online, AES online, it is absolutely amazing to get some of the archive presentations in there. It is, and we were selling them.
Right.
We were selling them for under $400. And people were buying those recordings, and now you can actually be a member and get those recordings. And so it's like, I don't know how long that's going to be happening, but that is a must have.
Yeah, for sure. So, okay. Back to TMD and occlusion. Besides a comprehensive exam in a history, do you have any adjunctive tools that you like to use? Like an ultrasound or a JVA, or do you send people for regular MRIs? What else do you play with in that world, if anything?
Yeah, sure. I'd love to share that. I think one of the things when I started to learn more about TMD and occlusion and get excited about it, I asked, what do I need to get? What do I need to buy? Right. And so what I learned that you can probably get, right, 80 to 90% of the information by just some deep, active listening.
That's right.
Right. From understanding where the patients are coming from, observations, and getting a good patient history. So doing what you do, right, on paper, going through your steps of asking questions and getting a very, very good history, you will have a very, very good idea of what's going on in that patient. And it didn't really hit me until I got those, toys, and I realized that I'm still going back, and I still kind of know what's going on even before I start them. So I just have a whole level of appreciation of just, and this is all of our mentor-isms of like Mary Osborne isms and Joan Undershoot's isms and the Pankey, and we've got LD Pankey, and then we've got Pete Dawson, and all those things all of those learnings, I think, have really just like kind of hit me to know that it comes from a really good comprehensive exam. So, so with that being said, what I do have is I do have a CBCT. I think it's becoming very good it's becoming more standard of care in all of our interdisciplinary fields now. I will routinely get a CBCT, and if able, I will also get an MRI, depending on what the patient presents with. So if I feel that the patients are not getting better over time with my initial bite splint therapy or my initial TMD therapy or my initial findings, I tell patients you're going to get better, you're going to get worse, you're going to stay the same. And all of these three things are okay because we're going to be learning. I also have a T-scan. So especially it's really nice to kind of dial in final occlusion or just to learn from a diagnostic, and not to mention it's a very, very patient education tool as well. So I love those things because patients want to learn. Like they see those graphs, they know what's going on. I love sharing that with them. And then recently I did just get a JVA. So, and that's new in my toolbox, and that's something that I'm excited to share. But also the most valuable thing in my toolbox are this right here, my two fingers, right?
Yeah.
Or the bell part of the stethoscope, so, and just being able to listen and to understand the joint sounds, I think sometimes less is more.
Yeah. Yeah, some of those tools, and you alluded to this, some of those tools are helpful for us, but they're even more helpful in how they allow you to share the information with the patient. So when they can see a graph of the way that their teeth are biting, or when they can hear the sounds that their joint is making, or see on a graph what their joint does whenever it's making a pop or a grind or whatever, I think it helps them with the whole process and understanding better what they're going through, because they don't know the anatomy. They don't know what's happening. Sometimes they're in pain and they're scared and they don't know if it's ever going to end. And so having those little pieces that they can hold on to as help and maybe as hope, I think just contributes to helping the whole process. So as you said, though, I think it's easy to, what I found, so I played with a number of those things through the years, and I found that at first, when I would first try to use those, my conversations were reduced. And I found then I would be lacking as I'm looking at the graph or whatever, like, oh, I should have asked these things. And so I had to really make a concerted effort that even though I have these tools, I can't let the foundation slip.
Yeah.
That makes sense.
Exactly. Yeah, exactly. Yeah. We just want to use them as just to support our findings.
Yeah.
We want them to support us, not be our definitive form of our diagnosis.
Yeah. Yeah. It's good. What is your favorite procedure under the microscope?
Endodontics. Just kidding.
Yeah. I knew you were going to say that for one of these answers. So favorite thing to do under the scope and favorite thing to do without the scope?
Favorite thing to do is any type of anterior preparation, any type of anterior veneer. I just love just preparing, just the ease and just the illumination and just the visual and just the magnification. Anything on the anteriors, I just absolutely love. And with proper isolation, it's just, it's so fun. Without the microscope, I love making bite splints. I love TMD in my practice. Yeah, I love going through and sort of understanding and breaking down sort of the systems or understanding the breakdown. Right. And so a little bit of what I always love teaching is, we start from teaching the joint. Start from the joint. Of course, we start from the comprehensive exam, but treat the joint and you finish with a final smile. But it has to start with joint stability. And so that's sort of my stitch in terms of how I like to treat patients. And I actually like to verbalize that too. I also say how passionate I am about, treating patients and understanding the joint muscles and then the teeth. And so that's how I tailor my comprehensive exam. That's how the patients that enter my practice know that that's just, they're just not going to get here and I'm just going to start looking at teeth. I'm going to look at the system. So I really enjoy doing that. And so I feel like we have a very patient-centered practice. And so it's part of our mission is to have a very patient-centered practice. And a part of that, I feel like starts with, I feel like TMD really helps us to do that too.
Yeah, for sure. It's so conversation heavy that I think you have to be able to do that in order to thrive in that kind of practice. Okay,
it's like a little bit about the marketing too, right? It's a little bit of marketing. You know, I read something about your brand. Like, what's your brand, right? Is it just your logo? So if you see, I've got a logo, and I looked at my logo. It's like, I said, what is a logo? Like, what's in a name? You know, and I realized is your logo. What your brand is. What people say about you after they leave your practice. I feel like that's your brand.
Yeah, that's
right?
a great way to put it. Yeah.
Yeah. So I said, so that's sort of kind of what sort of I want to focus on too, is just not only doing that, but saying really, really empowering patients to want to seek really healthy overall dental wellness.
Yeah. That's great. When you're making splints, do you make your own from scratch, or do you have a lab that does most of it?
Yes. So I get asked this question many times with when I'm teaching at the Institute. And I always say there is, principles, right? Stay the same. Methods can change. So I think we all have some really solid principles in how we want to do dentistry, and just what works in my hand and in my practice is I do make them, I want to say from scratch. You know, I want to say from the beginning, from the diagnostic record taking. And again, principles stay the same, methods will change. And so there are times where I'm scanning. I've got an iTero scanner, so I'm scanning the patients and I'm printing the models, but I'm mounting the models and I'm getting proper records, right? So I'm getting what I think is a CR bite record, and there's many different ways to get a CR record. I'm getting the protrusive bite, I'm mounting it, and then I'm making the shell. And there's two materials I use. It's called a bio isochrome material. It's a clear material, and then also your standard, just your mottloid. So I make them both ways, and it depends on what I feel like is best for the patients. And then I reline it right in the patient's mouth. And so I've had labs make it in the past. I've had shells made, and I relined it, but just over the years, I've just been able to train my team also, right? Because it really just does take a village. It takes a lot of intentionality to bring the culture of the practice into this TMD world, right? Because they need to make these bite splints for you, and they need to be able to get those records and know that we are a record-taking practice, And you alluded that you just hired a hygienist, but we all know what it entails if hiring new team members, if they're not used to. I've had many team members join the practice and say, what's a FaceBo, or what are you doing there? And so, I think that's more common than not. I want to say, at least where I am, I think it's very different in different areas, but some of my team members I've had to train just from basics on. And so it depends on how you can bring that on, but there's absolutely, I think like it's absolutely okay if your laboratory or whoever you're working with knows the principles.
Yeah.
I think you can make it in the lab. I just have been able to train my team to be able to make the bite splints, and I've so it's been successful.
Is there anything else that you would like to share that I've not asked you about?
Oh, wow. Love the authenticity of our talk, and love the direction that it took, and love sharing you a little bit about my childhood, experiences, and kind of taking you through along that ride there. I guess my biggest thing is what do I want to share? I guess is just keep learning. I'm a big learner, and I think it's important for us to stay amongst like-minded friends and dentists in the community, to just sort of feel like you're not alone. I think it can be very overwhelming to be practicing, especially with those of us that are high achievers and we want to do the best. We want to be and be the best that we can be. I feel like sometimes that can become overwhelming, and sometimes the most difficult obstacle that we have to get over is ourselves sometimes. And so I think in knowing ourselves, it can be the biggest wisdom.
Yep.
And so I guess, leave everyone with a little bit of thought process of just continue, I guess, in this sort of where we are kind of, I want to say post-COVID. Can I say that? I feel like we're kind of on the other end of this, right?
As long as you're not in Canada.
Right? Oh yeah, I know. Exactly. Depending on where we are, but I feel like I think the pendulum is swinging on the other side. And I think one thing that's really helped me get through sort of all of the pandemic and sort of the challenges and all of us having to pivot through these hard times. And, we're all teetering between surviving and then thriving, right? There's a fine line there, right? On days I feel like I'm just barely getting by, and there are days I feel like I can conquer this, and everything else in between. I really practice a lot of mindfulness there, which is, I think, just John Kabat-Zinn. He is, I really love learning about him, but he put it simply. He said, it's just mindfulness is just like paying attention in a particular way, on purpose, in the present, and non-judgmentally. And I feel like that's really helped me get through sort of, enjoying the present moment, although albeit all the other stuff and all the other noise that's going around us, all the other storms, definitely it's an intentional act to exercise being present and having gratitude. I know that awareness is innately a part of us all. And I know that it's definitely has helped me. And I just want to spread that sort of thought process as we kind of live our life and go on our day to day. There's a lot of stuff that we can do to kind of center our core and center ourselves to just kind of take it in and appreciate the everyday life of human beings and not being human doings, right? We're always doing stuff, but we also can't necessarily understand how we can be. So that's sort of been my internal growth. I think I've talked a lot about my external stuff, but I think the biggest stuff for me is the internal stuff. That's the hardest growth ever.
Yeah, that was well said, and I'm gonna end it on that. So, thank you so much for being on the AES podcast.
Yeah, it was just a lot of fun, and enjoyed being with you.
Hope you enjoyed that wide-ranging talk with Dr. Lee. Covered a lot of bases there. I think a lot of good content shared. Hopefully something for you to take home with you. If you haven't already, check out aesvirtual.org for all the information about the online learning platform, the archives, and more. And check out aes-tmj.org for 2022 meeting information.